Kia ora, Ros. Great to see you. Thanks for coming on the Nelson Pod.
Lovely to be here.
So, first question for me is, because I'm afraid of blood and guts and stuff, why surgery? Why did you want to get into surgery?
So you shouldn't be a surgeon if you're afraid of blood. That's not going to work. It's really corny, but my mum was a nurse. My dad got a job down south, and so for a while we had to go to her workplace after school, because we couldn't go home. So I hung out in a nursing home a lot, and she had this cunning plan. She had a little old lady who wasn't eating and refusing to eat, so she sent me up to feed her, because this little old lady wouldn't refuse to eat for a child. And so I did that for a few weeks, and she started eating, and she got a bit better, and she got a bit perkier, possibly because of the interactions more than anything else.
Yeah.
And I went, and I thought, I kind of like this helping people, and so that was where it started. But I think my mum's a frustrated doctor, really. You know, she was of a generation where you were a nurse or a teacher or a secretary. There's no way you did anything else. And I kind of like fixing things as well, and I think nursing's an amazing profession, but the great thing about what I do is I also get to care for people, but occasionally get them better as well.
Right.
And I've got a sort of slightly morbid fascination about taking things apart and putting them back together again as well, and that works quite well.
Including people?
Including people,
Okay.
Yeah.
And when you say down south, we're not talking Invercargill, are we?
No, we're talking the UK, yeah.
And what part of the UK?
So I was born in London, grew up in Sussex, south of England, and then my dad got a job up in the north of England in Buxton in Derbyshire. So we were up there, and then we went back down south when he got promotion. So,
right.
So I sort of lived up and down all over the place.
Yeah. And so where did you start your training in medicine?
So I went to University College Hospital, which is the oldest med school in the UK, which is a sort of bizarre sort of brick building shaped like a cross. So that's right in the centre of London, literally off Tottenham Court Road and Oxford Circus. So I had the cheapest, shittest house, because that's the sort of the student accommodation, but you were literally on the doorstep of all these places. So it was a pretty cool place to go to uni, and a great place to be 20-something.
Okay. And how many years did you study for?
So 18 to 25. So over there, 24. So quite a few years.
Right.
Yeah.
I heard someone on the radio talking about dentistry and how you get into dentistry, and one of the things that we're talking about is when you first start learning how to use the injection that dentists use, famously, the students do it on each other. Anything like that when you're doing surgery?
Nasogastric tubes down each other. We did eye tests on each other. We didn't go as far as doing things up other orifices, thank God, but some pretty unpleasant things.
Right.
Yeah, we definitely practiced lines on each other and putting drips into each other. Yeah, in a sense, it's not a bad thing to. I sound like a real old fart when I talk to my junior doctors now, and I say, "Have you ever had a nasogastric tube?" And they've got no idea. It's like, well, we were made to do it to each other, so that we appreciated that it's pretty unpleasant, and it does make you really think about what you're doing and why you're doing it, because you know how it feels. Yeah.
And do you remember the first time that you were a fully qualified grown-up surgeon, and you pulled out a scalpel and cut into a human body?
I think you got to define grown up. I'm not sure I'm fully qualified and grown up yet. So in terms of when I was I remember the first time I as a surgeon, and I was a trainee, so I was a fully qualified doctor, but not a qualified surgeon. When I first did an operation on my own, I remember that. It was like I just fixed something on my own. Yeah, and that was an appendix. Yeah, that was pretty cool.
I don't want to sound gross, but do you remember making that first incision and thinking, "Here I go"?
No, but I do, across the years, I remember having situations where I've thought, I'm actually cutting into somebody. There is an element of, you have to be, not arrogant, but you have to have some self-confidence to cut into someone. And I certainly remember coming back from maternity leave and coming back to it and thinking, I'm just going to do this again. And actually, if you stop and think, it's hard to do. And the reality is, I don't like hurting people. No doctor that I know does, actually. And I kind of deliberately hurt people on purpose for a good cause, and they're anaesthetised. But I cut into people for a living.
Yeah.
It's not all of what I do, but it is definitely something I do a number of times a week. And it takes a certain kind of approach to do that.
Yeah.
And a certain kind of resolution. Because there are times when you're in a situation that's very challenging and you're really concerned that the patient's not going to survive, and you sort of have to just man up and put the suit on and go, I'm the person that's here and I'm the person that can do this, I'm going to have to do this. And you do that thing where you take control of the room and you go, I'm in charge and it's all fine, and beneath the surface you're furiously paddling and hoping that nobody can see that you're furiously paddling.
Reminds me of that line that you see sometimes in aeroplane movies or disaster films and planes going down, and the pilot says, the aircraft is mine, and takes full responsibility. Do you ever feel like a pilot? Do you ever feel like you're flying something when you're doing surgery?
There's a lot of similarities. I mean, in fact, I've just come back from teaching a course on human factors to junior doctors, and the airline industry, heaps of stuff that cross-references. You know, we talk about the fact, in an operation at the beginning, the leader or the pilot's the anaesthetist, well, actually the nurse, then the anaesthetist, then the surgeon, then the nurse again, and you're constantly handing over control just like a pilot and co-pilot do, and lots of checking back. Yeah, there's lots of similarities, I think. Yeah, you're right.
Confidence must be hugely important. Do surgeons ever sort of find themselves in a moment where they think, what the hell am I doing?
All the time.
Right.
We're human.
Yeah.
Yeah. But you have to then fall back on the fact that, bear in mind, I'd spent 6 years at medical school. I spent 10 years as a registrar, 2 years as a house surgeon, and I've been a consultant surgeon for 16 years. I have seen the odd thing, and I have been in a lot of situations. So, yes, absolutely, you have moments where you think, I'm not sure I can do this, or I'm not sure what to do. But then you go, look, I'm well trained, I know my anatomy, I know how to operate, I'm going to apply some principles, and even if it might be something I've never had to deal with before, I'm going to do the best I can, because the alternative's not doing anything. But we're absolutely human. There's no doubt that there are definitely times where I remember when I was a senior registrar post-exam, so I got my ticket, supposedly a consultant, but not quite finished my time, and I remember being down in the emergency department at North Shore Hospital, and a nurse ringing me from theatre, who was a very experienced theatre nurse, and said, come to theatre now. And I arrived, and she went, don't scrub, just put your gloves on. And there's that moment you're going, oh shit, this doesn't sound good. And I walked in, and there were 5 anaesthetists at the top of the table. There was a gynecology registrar in trouble, and a patient who was, and I remember realising that, where's the cavalry, and appreciating that I was the cavalry, and being absolutely petrified. But at the same time, you've got to get on with it, and and it was a good result, and that was great. But there is definitely it is that putting on a mantle. It's putting on your professional role and going, I have to do this, because there's not somebody standing next to me that's going to do it instead. Do
you have any idea how many people you've done surgery on?
Absolutely none. No, probably. I mean, I have figures about some things I do, but as I say, the first time I operated on somebody would have probably been 1998.
Right.
So I really don't know.
A lot of people.
Yeah.
Do you ever have a moment, like I was saying at the start, movies when someone gets stabbed or even shot, and they have a shot at the wound, I can't handle it. Do you ever have moments where you're getting into somebody's internals and you think to yourself, God, this is kind of gross?
No, but I'm not good with eyes, and I'm not good with mucus.
Okay.
Yeah, so everything else, blood and poo and all those things, that's fine. But I couldn't be a gynecologist, and I couldn't be an ophthalmologist, because that stuff I'd really struggle with.
Very interesting.
Yeah, but I sort of say to people, I go kind of from the chin down to your knee.
Okay.
So that stuff I can do. But
right.
No, I mean, like any job, when you're in the zone, you're doing what you're doing, and particularly if you're doing it in a critical situation, you're very focused on what you're doing. You're right. Occasionally you step back. My first registrar job, so my first job where I wasn't just a junior doctor doing clerking, was paediatric cardiothoracic surgery at Green Lane.
Right.
And these were neonates.
Yeah.
And so my job was to hold the heart and follow the ATO thread, which you can't really see with the naked eye.
I don't know what that is, but it sounds
it's tiny
terrifying.
Thread.
Yep.
And the consultant's wearing these special loupes that magnify everything. And luckily at that point I'm probably 28 and I can see that thread. There's no way I'd be able to see that without some kind of magnifying now.
Yeah.
And every now and again you just stop and think, I'm actually just holding a heart. And I remember that. I remember thinking, this is the freakiest thing. Yeah.
Do surgeons ever get together and have a few craft beers or vinos and sort of, when no one's sort of listening, say to each other, isn't what we do amazing? Like, isn't it unbelievable? Do you ever have those sort of conversations?
I think we definitely get together and have debriefs. The job we do involves a lot of emotion, a lot of stress, a lot of really big cognitive load. And there are definitely days and times where you need to go, not necessarily discuss the details, but just go, it's been a week,
Yep.
So absolutely. But you're right. Also, it's interesting, there's a number of, like everything, there's a whole lot of Facebook groups like there are for everything. There's a Doctors New Zealand one, there's a New Zealand Women in Medicine. And that's a conversation that's been happening a bit recently, because the system's under pressure and everybody's feeling under pressure. And the junior doctors coming through, one of them was commenting that this really, listening to the chatter, she was feeling pretty pretty overwhelmed because here we were all saying how bad things were. But then there were some really great comments back from people saying, actually, yeah, we're telling you about all the bad stuff, but it's also a massive privilege to do our job. And there are days you go home and you go, I just saved this person, or I did that person, or I felt, and actually that stuff's really important. So you need to share both the good and the bad. And you definitely need the support of other people who understand the kind of weird job you do. Yeah. Because it is a kind of weird job that we do. We get into the most intimate and difficult portions of people's lives, which is a real privilege. And most people don't get to see inside that stuff, and we do. So and have the hardest of conversations. So you can't do that and go home and just brush it off. It has an effect. Yeah.
So speaking of those hardest conversations, a lot of the work that you do is helping people with cancer. Yeah. Why cancer for you? Why is that something you're so interested in?
I think for me primarily it wasn't so much the cancer. It was actually what I did a degree in psychology along the way, and I really like to be not just somebody cutting things out and actually be able to help with the psychology and the emotional trauma of what comes with a cancer diagnosis. And breast, for instance, works really well in that situation. It's, I think, one of the most emotive cancers for many people. It's also one of the commonest ones. And it's very different to, say, bowel cancer or skin cancer, when the conversations I have are very different. And so I thought that's something that I wanted to be involved in and hopefully be good at and learn how to be better at doing. Yeah. So for me, that was a big push towards it, that psychology aspect and the being there from that point of view. In a sense, breast cancer is good because actually the figures are pretty good. Yes, there's high levels and high incidence, but the survival's pretty good too. And in fact, it's been getting better. So I get to have a fairly positive conversation where I can fix things and make things better. My other big cancer area is thyroid cancer. Again, really good cancer. I've got colleagues who do things like pancreatic and gastric cancer. It's not the same situation, so I get the kind of good end of it. So I think that would be more of a challenge. And I think for an oncologist dealing with just pancreatic and stomach cancer, and a good friend of mine is that person, that's pretty full on. So I picked the easier bit.
Right, very wise, Ros, very wise. Do you ever get sort of used to telling someone that they've got cancer? Do you end up sort of developing a sort of professionalism about it where it's just another day at the office, or is it different for every person?
I think it's different for every person, and I think it's different for every surgeon and every doctor too. I'm not good at being detached, and I've got colleagues who will be really quite professionally detached, and I've got others who will be probably even more emotionally engaged. The kind of teaching we say to people is that you need to have a degree of detachment because you need to maintain resilience. And if you go all in and feeling it for the patient every time, you can't sustain that. And unfortunately, on a daily week, I'll see this week so far, I've seen 4 new breast cancers. So if I give everything to every single one, I haven't got anything left. Sure. So but equally well, I'm not a professional detached sort of. It's a small town we live in. I know people. I know, and there's almost nobody I see that doesn't know somebody I know. It's it's 2 degrees, 3 degrees of separation at best. And so I personally, my approach is I'm just human. I happen to be another person. I'm giving them a tool, but I'm also somebody that might be in their kids' playgroup or be engaged in many other ways, and almost certainly have seen them down the pub or at a party at some point. And there's almost always a connection, and so it's natural to continue that connection. So I don't think I think the day that you go, it's just a job and I'm just 9 to 5 and it doesn't matter, it's probably the day you shouldn't do it anymore. So no, for me, it's always personal. I think what you need to remember, it's not my news, it's their news, and you need to try and tailor it for the person in front of you. For some people that they want to detach, other people want, a very different approach. And so you kind of read the room, and sometimes you get it wrong, sometimes you get it right. But there are sort of set pieces we know we do that help to make that conversation easier. But it's not like you've learned to list and you go, I've done my checklist, tick. That's just not authentic. So,
have things changed? I think, once upon a time, if you were told that you had cancer, I think a lot of people would think that was a death sentence. But increasingly, we know so much more about cancer than we do today. Do you think the way people respond to the news that they have cancer has changed?
It's hard to say because I can only talk about my experience and much as I've been doing this a while, I've not been doing it as long as, since I've been doing it, it hasn't been an automatic death sentence. So I'm lucky. In that sense, for me, that makes it easier for me and clearly better for my patients. I think there's still an emotional response for everybody. And you're right, the emotional response is to be stopped in your tracks. And some people then become information gatherers, others just switch off. So that's part of that whole reading what's going on. But I don't think it's, so I think it's always emotional. And you're right, there are certainly people that go straight to that's it, I'm going to die. And there are people that's the first question they ask. Yeah, and actually the honest answer is no, we can't tell you that because we don't know enough at that point. We know very little usually at that first meeting. And even once we've operated, we still only know some stuff, And I think that's the other thing that I think is really key, is just to be honest and you treat the person with empathy and integrity and actually say when you don't know stuff. It's okay to not know everything. That's one of the real challenges of people with cancer, is they want black and white, they want everything, and actually medicine's incredibly grey. But equally well, if your doctor's honest with you and says from the start, I'll tell you when I don't know stuff, and then you'll know that if I'm telling you stuff, it's because I do know. Yeah, I think that's really important.
Does knowing a lot about cancer mean that you worry about it more yourself as you go about your own daily life, or does it mean that you worry about it less because it's not mysterious?
I think I've got a skewed view of the world because the people I see, everybody I see in my life, in my world, is sick. So I don't have it. And sometimes you have to remind yourself that that's a minority of the people that are out there. There's no doubt it makes you think about it. And certainly my GP would say that every ache and pain I've clearly got widespread metastatic disease. That's clearly where I go because that's my world. Yeah. And then you have to use some logical, rational thought and go, I probably just strained a muscle. I'm getting old, And so yes, that does happen. But I think you're also right. You also become reassured that actually that there's a lot of complexity and there's a lot of different things with different cancers and they're going to mean different things, and so that actually it's not a simple black and white thing. So you're more reassured that you understand that there's many options depending on where you're at. People often think that there are more people dying of cancer today because you get to a certain age and people who have died from cancer, or you certainly know people who've gone through cancer. What is actually happening? Are more people getting cancer, or are we just getting better at diagnosing it? So that's impossible to say for sure because we don't know who we didn't diagnose before. So I can't actually tell you that because who knows. I would like to think we're getting better at diagnosing it, and that's why the incidence is going up. And overall, probably the mortality is going down to a degree, but we are getting a higher incidence, so overall deaths are going up, if that makes sense. There's more people with cancer, there's more deaths, there's less rate of death. Right. Percentage death, but there is more cancer overall. And is that partly because we're all living longer as well? That's certainly going to be a part of the play. You have to die of something, and we were designed to live to 40 and eat probably berries and sort of antelope. We live to 80 and eat bread and pasta and a lot of meat, and none of that's particularly good for our bodies and leads to a whole load of problems, and they wear out and things go wrong. Yeah, absolutely. Part of your work does involve, obviously, death. Is that something you think about a lot? And what do you think happens when we die? So I don't think about death a lot, in as much as my focus is usually on trying keeping my patients alive and comfortable. But some of my patients die, and I think my priorities with death are making sure that death can be as good as it can be. There's that feeling that death is a failure from a doctor's point of view. No, it's a change of focus because it's a natural thing to die. I don't want my patients to die, but if they're dying, I want to make sure I'm doing everything I can to give them the best death they can have and to give their family that peaceful death too, because my dad's just died, and I know how hard it is when you're faced with the loss and the space of where the person was, and if you've got the comfort of knowing that it was the best death it could be, that makes a big difference. As to what happens, I don't know. I don't think anybody does. I'd like to think there was a space and a rest and a sort of sigh and a relief. That's what I'd like to think. I'm not going to even speculate about whether there is an afterlife or not, but I like to think my dad was somehow looking down. That would be cool. I'd like that. And that he was actually okay now. Yeah, that would be great. I like to think of myself as an optimistic agnostic. That's a good phrase. That's what I am, I suspect. Yeah, because I think atheism's too absolute. I think I grew up in the Catholic tradition, and I have that understanding and things, which was something I believed in once upon a time. But today I just think I don't know, but I'd like to think that there might be something. I think that's a great phrase. I'm going to adopt that. Yep. Yeah. So what about Nelson? How did you guys end up here? So part of your training as a medical student, you have to do an overseas elective. And I had an aunt living in Tokoroa. I'd never been to New Zealand, so that seemed a really good reason to come here and do a little bit of medicine and quite a lot of touring. And so I brought my then very new boyfriend and now husband of 26 years.
Mm-hmm.
And I did a very little bit of medicine in Hamilton and quite a lot of looking at the South Island. And one of the places we stopped was Nelson. We were meant to be here one night, but we stayed 3 because we really liked it. And then, New Zealand actually doesn't have enough doctors and is always advertising for junior doctors overseas. And there was an advert in the British Medical Journal saying, come to New Zealand, be a junior doctor. And it was interesting because this is 1995, and it said, and we will pay half the fees for your wife. So I applied and said I didn't have a wife, I had a husband, and surely they weren't going to be sexist, and they were really embarrassed, and so they went, yes, of course.
I'm hoping that was a British ad, not a New Zealand ad.
It was a British ad. Oh, no, well, it was a New Zealand ad in a British journal, so it must have been written by Waikato Hospital.
Wow.
So I pulled them up on it, and they felt bad, and they paid for half of my husband's fare as well.
Good.
And you had to stay for a minimum of a year, so we were coming for a year. That was 1996. It's been a long year.
Mm-hmm.
After 2 years here, my mum's going, you said you'd gone for a year, so I promised to go home. So we went home for Christmas, and we were meant to stay for a while, and she bought us the biggest, highest standard lamp you can possibly imagine. Clearly, right, we're going to buy you something so big that you have to stay, so we shipped it back.
Lamp.
It was a massive lamp, but it was clearly we're going to buy you something that means you have to stay here. Yeah, so we shipped it.
And did you make the right call coming out here?
Oh, completely. So we came out and we worked all around the country, and I was lucky enough, and in fact, because we'd been to Nelson on that tiki tour, I applied I wanted to be a registrar here, so I came here in 2003 for a year. And I'd always worked in big places. I'd come from London, I'd worked in Christchurch and Auckland, never really saw myself in a small place. And then I found Nelson, and I was like, actually, this is really cool. Yeah.
Nice. And so we've got a lot of change happening with medicine in Nelson Whakatū. We're getting this new hospital. Is that an exciting thing for someone who works in medicine?
It would be really exciting when it happens. I've been hearing about the new hospital since 2003.
Yep.
I'm just going to hold my breath.
Okay.
Yeah. But yes, we desperately need a new hospital. We are under-resourced, as is the entire of New Zealand's health service, and indeed globally. The problem is the population's ageing, it's growing, and successive governments everywhere around the world say we've given this much cash, but they don't put it in a percentage. If you look at the percentage, they've given less every year, and we need more every year.
How does the state of New Zealand's medical system compare to the national health system in the UK, which is a great source of pride for British people?
I think the National Health Service is an amazing system, but it isn't anymore. And I think it's really broken, just like here. So currently, both the junior and the senior doctors are striking. In fact, they're striking today. So it's the first time they've had an overlap with both seniors and juniors at the same time for 2 days straight, because they're in just the same state. I did look up some figures. There are 15 million health workforce vacancies worldwide.
Right.
Yeah, so everybody's struggling. Yeah, so New Zealanders, we have that tendency to look at what's happening here and not look outside of ourselves sometimes. And the bottom line is that New Zealand has had probably a couple of decades of under-resource in the health service, and then we had a global pandemic. Yeah. So you had a workforce who were already at the edge and on the really on the precipice, and then you did 3 years of making them work like they'd never worked before, and it's broken. Yeah.
So the hospital, it's a hugely exciting project for Nelson, and you got to think it's going to be a great thing. But it does occur to me occasionally that the idea of having a hospital, big building, everyone in the one sort of structure and everything else, seems like a kind of an old-fashioned way of doing things. Like, has the concept of a hospital changed that much over the last 100 years?
I think we've got much more community-based stuff, and actually that's alive and kicking in New Zealand and in Nelson. There's a lot of community-based stuff, GPs, community clinics, outreach centres, all that stuff's really important, and as much as possible, you want to do as much as you can, not in the hospital, because you want to keep people in the homes and in the place where they're actually surrounded by their support group, their family, their friends.
Yeah.
But there's always going to be, I'm not going to be taking your thyroid out in the street or on your bedside table. You do need a hospital with functional, high-level, sort of monitoring and support. So I think hospitals are always going to need to exist. But you're right. There are some things we can do more, in a more intelligent way and in a more sort of community-based way. But the kind of stuff I do, you're going to need a hospital.
Would you recommend medicine to a young person today?
I would. I'd give there's some caveats. Yeah, it's not a easy life. I've just spent the last week on call, and I was in the hospital for 17 hours on Monday. I was in the hospital for 11 hours yesterday. Today was a good day, but I'm on call again from Friday and I'll do 72 hours straight, day and night, and then work the rest of the week. So people often ask me if I do shift work. No, I do all day and then all night and then all the next day. So it's not a particularly family-friendly job. I miss both my kids walking. I miss both my kids crawling. I was at work for all of those. I've missed a lot of Christmases and Easters. But I'd say, actually, it's a huge privilege. I get to meet people, as I said, in their vulnerable and most intimate time, and actually I get to look after them, and I get a lot of laughter out of my job. It sounds odd, but I often have laughter with my patients when I'm telling them they've got cancer. To me, that's a sign that the conversation's gone well, because we get to talk about all the sort of stuff that's driving them insane and stupid things people say to them, and actually you get this amazing. You get to watch the strength of some people, and I'm always inspired by how strong people are.
So, what are some of the stupid things people say to people who've got cancer?
Oh, all sorts. So I've had people tell me that I remember lovely ladies told me, I think I'm being grumpy. I said, why is that? She said, well, because a woman came up to me in the supermarket and she lost her hair from chemo and said, is your husband left yet? And she's like, I don't think that's grumpy. I think that's just, she's just insane. But all sorts. And people make stupid comments all the time. They don't know what to say. So I think actually saying something's better than saying nothing, because it's the other group that just avoid people. And, and if you talk to people about cancer, they don't want to talk about cancer all the time. But they also don't want you to treat them like they're going to break if you drop them. So you're allowed to still shout at them and laugh at them and make fun of them, because actually they're still human and they actually need their mates to be human with them still. And then there's sort of different reactions, and I get that people find it a struggle to talk about cancer and they're scared about it, but it's not contagious. They're going to they're not a leper. You can actually touch them and talk to them. And I have great conversations and heaps of laughter with my patients, because I just treat them like normal, and a lot of people don't treat them like normal when they've got cancer, and that drives them potty.
We always hear about the opportunities that exist for people with your skills offshore. Are you tempted to take off now that your kids are grown up and go and make some really major bucks overseas?
Not for me, no, but I'm really worried about the next generation, and that the SMOs are striking. This is the first time we've ever struck, and I'm never leaving, and I suspect most of my colleagues aren't. But currently, just Australia, first-year consultant will earn double what we earn. So how there's a whole group of people coming through who, I can, millenniums are going to go, why would I be staying here when I could go and make a lot more money? One thing I might do, and me and my husband might do, is go and when I'm not useful here anymore, is maybe go and do a little bit of relief work. I'd love to go over somewhere like Fiji or some Pacific Islands and help out there, where they're always looking for help for 3-6 month blocks. And set my husband to work. JP can build a school or do some IT stuff.
Good idea. Yeah.
So I'd like to do that. But that I could do that as a sabbatical, or I could do that when I'm retired. But no, I'm not going anywhere. I love Nelson. I feel living here I get a real privilege. I get to look after this community, and I think Nelson being small, it's got pros and cons, but you get to feel really part of a community, and it feels like a real privilege. And every time I fly back in, if I've been away doing something somewhere and I come back, I always sort of feel like this is the group of people I'm looking after, and I feel a sense of responsibility for that. And it is a real privilege. So no, I have no intention of going anywhere.
Well, Ros Pochin, thank you very much for looking after us. Truly, thanks for being part of this community. Thanks for everything that you do for it. And thank you very much for coming on the Nelson Pod. It's been a pleasure talking to you.
It is a real pleasure. Thank you.